I'm Dr. Fakir Avadi. Welcome to this episode of Clinical Microlearning. Here's a self-assessment question. A 65-year-old male with a history of COPD was admitted with suspected bacteremia. He's currently on empiric therapy with vancomycin and cefepime. Blood cultures are growing Staphylococcus aureus sensitive to oxacillin and clindamycin, but resistant to erythromycin. What is the best option for this patient? Please pause this video and think about the answer. The correct answer is E, switch to nafcillin. Now, when we look at Staphylococcus aureus bacteremia, when we look at sensitivity results, the first thing we look at is oxacillin. And when it is susceptible to oxacillin, we label this as MSSA. So essentially, we want to have the most optimal treatment for MSSA. So because we know exactly what we're dealing with, we no longer need to continue the empiric combination of vancomycin and cefepime. So we can get rid of that and streamline the treatment. Now the question is, will vancomycin have activity against MSSA? So essentially, vancomycin, cefepime, ceftriaxone, nafcillin, and clindamycin, they all should have activity against MSSA. With regards to clindamycin, because this is resistant to erythromycin, one need to do the D test to find out if clindamycin might could potentially have inducible resistance. And besides that, clindamycin in general, whether susceptible or not, is not the drug of choice for Staphylococcus aureus bacteremia due to limited data with clindamycin. So drugs of choice for MSSA bacteremia include anti-staphylococcal penicillin such as nafcillin or oxacillin, or first-generation cephalosporin cefazolin. When it comes to vancomycin, observational studies show that vancomycin, although active against MSSA, has inferior efficacy compared to these first-choice options in regards to mortality. Now, with regards to other beta-lactams, observational studies again suggest that ceftriaxone and piptazo may have inferior efficacy compared to cefazolin and nafcillin or oxacillin. So for that reason, when we know that the patient has MSSA bacteremia, the drug of choice will be cefazolin or nafcillin. Here's another self-assessment question. A 55-year-old female with a history of heart failure was admitted with suspected bacteremia secondary to surgical wound infection. She's currently on empiric therapy with ceftriaxone and vancomycin. And again, blood cultures are showing Staphylococcus aureus, but sensitive to vancomycin, linezolid, tetracycline, and daptomycin, but resistant to oxacillin and clindamycin. What is the best option for this patient who is clinically improving? Please pause this video and think about the answer. The correct answer is B, switch to vancomycin monotherapy. Again, when we have Staphylococcus aureus, the first thing we look at is if the organism is resistant to oxacillin. So in this case, it is resistant to oxacillin. So we label this as MRSA. So essentially, we want to use agents active against MRSA. Vancomycin happens to be one of the drugs of choice for MRSA bacteremia. Of course, we want to avoid ceftriaxone because it does not have activity against MRSA. And because this is bacteremia and there is a risk of mortality, we want to avoid proven drugs even though they have in vitro activity. So doxycycline, for example, may have in vitro activity against MRSA, but it is not appropriate to use for bacteremia due to lack of data, especially with tetracyclines in general. The PK/PD of them may not be optimal in the blood due to their large volume of distribution. The same with ceftaroline, although active against MRSA, when you do have vancomycin or daptomycin available, should not be used in the absence of proven efficacy. And linezolid, although it will probably be effective because MRSA bacteremia is often treated for a long time, at least 2 weeks, and in the case of complicated MRSA bacteremia for at least 4 weeks. And linezolid is associated with toxicity when used long term. For that reason, it's typically not used as first line. So the correct answer is vancomycin monotherapy. So either vancomycin or daptomycin are preferred for MRSA bacteremia. Here's another self-assessment question. A 45-year-old female in the ICU with abdominal surgery is receiving empiric therapy with piptazo for suspected bacteremia. Blood cultures are growing E. coli sensitive to ceftriaxone, piptazo, meropenem, and amikacin, but resistant to ciprofloxacin, trimsulfa, and cefazolin. What is the best option for this patient? Please pause this video and think about the answer. The correct answer is D, switch to ceftriaxone. Now, when it comes to Enterobacterialis, one of the first things we should look at is resistant to ceftriaxone. So if it is resistant to ceftriaxone, we suspect ESBLs. In this case, it's sensitive to ceftriaxone, so we don't necessarily have a concern for ESBL producing E. coli. And because the empiric treatment in piptazo is broad, it has pseudomonal activity, and we're not treating for pseudomonas, so we should de-escalate to the narrowest possible. In this case, because trimsulfa and cefazolin are actually, E. coli is resistant to these, they're not appropriate choices. So the narrowest option from the susceptibility results would be ceftriaxone. So in general, for gram-negative organism, we choose the narrowest agents. In the case of ESBL, carbapenems are drugs of choice regardless of susceptibility results. Make sure to subscribe and like this micro moment video.